The aim of this lecture is to introduce some protocols for post-surgical intervention. Just a bit of an introduction to myself. My name is Dr. Chris Norris and I am a physiotherapist. I have a master's degree in exercise science and I actually did my doctorate at Staffordshire Uni, so that was in spinal rehabilitation. So I'm essentially a clinician and a teacher. And what I'm aiming to do with this really is to give you some familiarity as to what goes on around the surgical process, what physiotherapists do and what sport therapists can do and how you can fit into this role. So our aims for this session then, what the physiotherapist role is for pre-surgical intervention, so before surgery, what the physiotherapist role is immediately after surgery up to the 6-week period, and we'll talk a little bit about that later, and then importantly what the sport therapist's role is after that 6-week period. And we're going to be looking at a number of examples, but the main example we're going to work around is the hip replacement operation, because it is so common and also it illustrates the principles around which will work for other forms of surgery. So pre-operative period then is before the person has the operation, post-operative is after they have the operation. So we have to consider what the person is going through. So you don't just have an operation for no reason. You will have built up a period perhaps of 1 or 2 years of pain and deconditioning, and in many cases it may be up to sort of 5 years where the person has been walking differently, they've been using their functional activity, so driving, using the washing machine, walking the dog, etc. All of these things will have been changed because of the alteration in the hip and because of pain. So we've got this aspect of deconditioning and the considerations around that, and we need to be looking at the education we're going to give to the patient, both before and after surgery, and obviously the exercise before and afterwards. So we've got our planning, what's going to happen immediately when you're discharged from hospital, and the surgical approaches with a view to their effect on the patient's general health, because whilst hip replacements can be done on younger people, on the whole you've got an older person with other things wrong with them, so-called comorbidities. So you've got a deconditioned patient with comorbidities who's in pain with an altered gait. So that's what we have, pre-operatively. As we look at the post-operative period, we allow for the tissues to heal, and so traditionally there's a sort of a 6-week period for that, and at 6 weeks you'll have an appointment with your consultant, and normally you will then be discharged, and it's what happens after that discharge which is very, very important, because if the person is simply discharged and you say, well, off you go back to your normal life, and they've spent up to 5 years gradually changing the way they've been acting and the way they've been moving their hip, obviously that's not going to directly reverse itself instantly. So let's have a look at a video now, an NHS video on what happens prior to a hip operation.
Started playing up. The pain was really when you're putting on shoes and socks and having to bend, and that was actually very, very painful. One of the great pluses about the operation is that now I do this without a moment's thought, but prior to that it was almost impossible.
This procedure is first and foremost a pain relieving procedure, and that is the main reason to do any form of joint replacement and hip replacement surgery. And well over 90% of people who have a hip replacement are really pleased and satisfied with the outcome of their surgery.
Every patient has an assessment before they have their surgery. It's like a full body MOT. You'll see a nurse, they'll take some bloods, you'll have your observations taken, your blood pressure, pulse, etc. And they'll go through a questionnaire picking up any health problems or family health problems you might have. It's also useful to bring in a list of your medications to this appointment because they'll want to know exactly what medications you take and what for. We'll do what we can to make your health as good as possible for the day of your operation.
I felt reassured after the pre-assessment clinic, very reassured that yes, I was fit for the operation. Anything I was worried about, I was able to ask. So I came away confident that when the day came, when I got the call, I'd be ready for it. She explained very clearly what was going to happen, so I had no worries.
Total hip replacement surgery is an elective procedure, so we have the luxury of time to prepare. You're not likely to be with us for very long, a couple of days maybe if things go according to plan, and that's a good thing, and we want you back at home. We would ask you to think about being prepared for that discharge. We know people prepare to come in, they don't always think about preparing to go home again.
But preparation is actually very important. Telling your neighbour, telling someone, a relative, that this is happening. And if you can get someone to stay, so much the better. A neighbour next door coming in regularly would obviously be a great help.
One of the keys for a successful recovery is being prepared for the recovery period after the surgery, which is one of the reasons the occupational therapists like you to prepare as much as possible before you come in. If you make sure that you're well stocked with food at home, so things like microwavable meals are a good choice.
So when you're packing to come into hospital, don't bring too much stuff with you, just a small bag please. Bring some loose fitting clothes. It's really good to get yourself up and dressed after the operation rather than being in your pyjamas the entire time. Bring a basic wash kit. You need some good sturdy shoes, slippers that aren't going to fall off your feet, things that are comfortable for you to wear and not too tight.
On the morning of your operation, we like you to take your tablets as you would do normally, unless you've specifically been told to miss something out. Some people are taking blood thinning drugs as a tablet. You're normally asked to stop those several days before you come into hospital. From an analgesic point of view, the only tablets we don't want you to take are from the group of drugs called non-steroidal anti-inflammatories.
We would like you to bring all your medicines into hospital with you. We will have a look at them and we'll go through them all with you so that we've got an accurate record of everything. With your permission, we will use your own medicines to give to you while you're in hospital, and then when you're going home we'll make sure that you've got at least 2 weeks supply of them to take home.
I turned up and I was told I had to look for this theatre direct admissions place to go in. So I looked for that and went on in, and they were just so welcoming, such nice people.
Everyone is expected to start arriving from 7 a.m. If it's going to be any different, someone will give you a call and tell you the day before. Cubicles are used when there are things to be discussed or checked or examined. You will be seen by all practitioners required, the surgical team, the anaesthetic team. Essentially, what needs to be checked is anything that can interfere with safety or outcome of your operation. Regain your consent and they will be walked into theatre.
I was able to meet everyone who was involved in the operation. So that meant the anaesthetist and the surgeon and other people supporting. They made certain that I knew what would be going on, each of them. And I was able to talk to the anaesthetist as well about what sort of anaesthetic I wanted.
It's important that you don't eat any food from 6 hours before the operation. If you're going to drink anything, then that's up to 2 hours before the operation. If you've got food in your stomach, it can come up and go into your lungs whilst you're under an anaesthetic. So it is really important that you do fast as you're advised to.
I was told that obviously it wasn't just me alone doing it, there were a number of people, and that I might not be first, I might be a long way down the list. So I took a book. I like reading, that was great.
There's 3 ways that you can have an anaesthetic for a hip operation. You can either have a general anaesthetic, you can have a spinal anaesthetic with sedation, or you can have a spinal anaesthetic and you stay awake. The most common type of anaesthetic that's done for a hip operation is a spinal anaesthetic. You can feel movement of the leg and soft touches, but you don't feel anything painful. If you do feel anything, then you must tell your anaesthetist immediately.
When we get into the hip joint, we dislocate the joint, and the ball we actually cut off, and that is normally sent off to the laboratories for them to have a look at. That then leaves the hole that we need to fill in with your new hip replacement. And where the socket is on the pelvic side, we mill that out, and we put in either a plastic socket which is cemented in, or we put a metal shell which then has either a plastic or ceramic liner. The femur is actually a bit like a tube, and down that tube we put a metal pin, and again that pin's either a cemented pin or an uncemented pin, and on that pin is the new head, which again is a metal or ceramic head. So there are different combinations of hip replacements out there and available, and we try and personalise that hip replacement to the patient themselves. The majority of risks are around about 1 to 2%. But if they're a significant one, then we feel it's important that the patient does know that. What I normally say to a patient is that to do the operation, I've got to cut the skin, so there's a small risk of bleeding, there is a small risk of infection, there is a risk of dislocation, and that means when the ball comes out the socket after surgery. The risk of dislocation is highest in the first few weeks to months after surgery, because that's the time of healing after the surgery itself. When we do the operation, we try and get people's legs the same length. We can't guarantee to get them exactly the same, and actually the majority of people have a slight leg length difference anyway, and we're trying to just recreate what is normal for them. There's a very small risk of damage to the nerves and vessels, which remain close to the hip at the time of surgery. There's a risk of getting blood clots in the legs, and there's a small risk of blood clots in the lungs. There are obviously medical risks following any form of surgery, and those can be things such as heart attacks, strokes, chest infections and kidney problems, and they're obviously dependent on the patient's fitness prior to surgery, and that's one thing we're very careful about, that patients are pre-assessed before their surgery to try and reduce the risk of these problems as much as possible. We always try to improve things, and we're trying to gradually improve how we do things, both on the operative side and on the implant technology side. It is a balance. You want something that you know is going to work well and last, but also you want something that hopefully is going to do better than the last ones that you have developed. To reassure you as a patient in relation to the success of this procedure, we do over 800 hip replacements in this hospital with satisfaction rates of over 90%, then it is one of the best operations there are for improving quality of life.
What we do in recovery is to establish airways, which is mean you're breathing fine, your lungs fine, and you're getting enough oxygen to your organs. Once that is established, we then start to think about the rest of the body. We also need to make sure that you're well hydrated, and we'll give you fluids intravenously and blood if need be. So all that are essential. It needs to be initiated in recovery, even if it's not completed there.
I sort of gradually woke up and people were around and talking to me. You know, come on Liz, how are you feeling? So I sort of gradually regained consciousness. But there was always people there, and that was very reassuring. And I felt great. Yes, I thought, that's over, didn't matter at all. And I know I'm going to get better now. I've got a future, you know. I'll be so much better after this.
If you had your operation asleep, you may wake up just before you arrive in recovery. You may wake up in recovery. You will have an anaesthetist, a nurse, anaesthetic nurse. Minimum of 2 of those 3 people will be with you while you're waking up. We try to make sure that we anticipate pain before they arrive. We load you up with painkillers ahead of pain.
The spinal anaesthetic lasts approximately 2 to 3 hours. It does vary a little bit between patients, but that's the typical time. As it wears off, first of all, get a bit of tingling in your legs and you'll be able to move them again. Some anaesthetists will put an extra painkiller in the spinal anaesthetic, so that lingers around for about 8 to 12 hours. One of the side effects of spinal anaesthetic is urinary retention, so not being able to pass urine. If that's the case a few hours after the operation and you're still unable to pass urine, then a catheter will be inserted. But because of the risk of introducing infection with a urinary catheter, it's not done as standard.
You will be on your back most of the time in the first 24 hours, It's not a no to lie on your side, but you would find you may not be able to stay on your side for too long. It could be tender, and the nurses will need to keep looking at the wound. Don't feel anything is too much to ask. Express your fear so they can reassure you. Recovery is a short stay area where we really don't encourage visiting. What we ask is that the family identify one person who will ring regularly to get updates and tell the rest of the family. If you're awake and you want the call, we will pass it on to you. Recovery is in two parts. Some people will be staying in recovery overnight, which then means they are now in HDU, what we call high dependency unit.
There's always pain with a bad hip. That's why you start to think about what should I do about it. And it's wonderful that just having the operation takes it away.
And quite honestly, the operation, he was fantastic, the team were fantastic, and I had no problems with them.
Okay, so a couple of things to note from that then. Firstly, it's a sort of a scary thing for people, but you can reassure them that at any one time they're not going to be alone, that everything's going to be very human, it's going to be explained to them, everything is controlled. A couple of things to note there. The first one is, that people shouldn't eat beforehand. So if you're a personal trainer or you're dealing with individuals, perhaps to remind them of that, because if you throw up, then the food could be inhaled. And the second thing is that not to take non-steroidal anti-inflammatory drugs, so NSAIDs, and the reason for that is that the inflammation is part of the healing process, and you want that to continue unabated. So just quickly going through the surgical procedure then, so it could be done as an inpatient or as an outpatient. So an inpatient would mean where you stay overnight, and an outpatient would mean where it's happens all within one day. So even though you've gone in at 7 in the morning and you might not be out until 7 at night, that would still be an outpatient procedure. Nil by mouth the night before, so that you're not going to sort of throw up, and most people are nervous, so they probably won't feel hungry anyway. You'll then have a medical examination, because I mentioned that as we saw on the video, we've got somebody who is older and deconditioned, because when you're limping like that, you can't be running or going to the gym or whatever. So they're going to be looking at things other than the hip. So they'll be listening to the heart, using an ECG, looking at taking a blood sample, looking at cholesterol levels, these types of things. So they're concerned with the patient's general health. They use an aseptic technique, so in other words, everything is sterile, and that video was done some time ago. With coronavirus now, then that would be even greater sterility. The patient is put into a surgical position, so that position may be different to one which they are used to, and so they're going to get a few aches and pains simply from stretching muscle and leaning on bits and pieces that you haven't done for a while. What you saw around that area was two groups of individuals. You had the surgeon and the assistant standing fairly close in. You had the patient, where there's an adhesive film put on the skin and then drapes are around, and then you had a second group of individuals, the anaesthetist and nurses around, theatre assistants around, where they were away from that directly sterile area. So you've got a sterile and an unsterile area within that operating room. The anaesthetic then can be one of two things. It can be something where you just sort of knock the hip out, as it were, so a local anaesthetic where the patient is awake, or they're conscious certainly. Often they'll have dark glasses on so they can't see easily, and they may have headphones on so that they can't hear things. Playing music or something, and then a general anaesthetic where the patient would be unconscious, and there are advantages and disadvantages of that. And then they have drugs to administer, and those drugs are administered initially through a sort of an injection, and then through an injection into a tube which goes into the vessels in the forearm, so that would be your intravenous drip, and also through gas, either through a mask or through a tube onto the face. So let's have a quick look then at this whole concept of general anaesthesia. Remember, this is something which is relatively modern, only about 100 years or so. Prior to that, you'd sort of be held down by people and somebody would sort of saw your leg off. So, it's something which is new but ongoing. I trained 40 years ago, and the anaesthetics have changed considerably from that time. But let's just go through the sequence. So the first thing that happens then is you have a pre-med. So that's before you're in the operation, in the operating theatre, and that will reduce your body's natural reaction to shock. So shivering, anxiety, nausea, these sort of things. So the pre-med is designed to calm you down and reduce that. And then once you've got the anaesthetic, you go through a couple of stages. So the first stage is called the stage of induction, and that is where the analgesia, which is pain relief, progresses to amnesia. So you have no memory or very little memory of what's going on. So something. If you're having a local anaesthetic, it may just be that the pain has been suppressed, but where you're having a general, memory will be suppressed as well. Stage 2 then, the stage of excitement, the respiration and the heart rate becomes irregular, and at that stage breathing stops. So in stage 1 you're still breathing a little bit like you're in a deep sleep. In stage 2, breathing stops. So that's when you need your airway, which is essentially a tube which goes down the throat to make sure that the airway, the trachea, doesn't collapse. And then stage 3, the anaesthetic stage, everything is knocked out. So the muscles relax, eye movements stop, pupils dilate, and the intercostal muscles are knocked out. So, and the reason for that is that you don't want muscles to be twitching while you're having surgery. If you watch somebody asleep, if you've ever watched, pet a dog or something asleep, you'll see that they twitch and their paws go and all this sort of thing. So even though you're asleep, muscles can be active. So as part of this stage 3, you're knocking the muscles out. So the machine then needs to breathe for you, and you have no muscle reaction to protect yourself. So moving limbs and positioning the patient becomes very, very important, because if you drop somebody's limb, they have no muscle reflex there. So they've got that unconsciousness, so lack of motor reflexes on the left column there, unconsciousness, and then paralysis of the skeletal muscle itself. And then as you come out from your general anaesthetic, it's a little bit of a reverse. So there may be a little bit of confusion, shivering, nausea, sore throat and mouth from where the airway has gone in. And those are all familiar to the people who are standing with you. And that's why they're there, to reassure you. You've done it once, they've done it 800 times. So they're there to reassure you. So we're going to look at a couple of small videos here then to look at the anaesthetic types used in joint replacements, and then we'll also look at some general anaesthetic principles.
At King's, we carry out over 2,500 joint replacements every year, so you can be assured that you're in safe hands. From the moment we see you in the pre-admission clinic on the day of your operation to the moment you leave hospital. My name is Dr. Oliver Long. I'm a consultant anaesthetist, part of the specialist anaesthetic team here at King's. We care for patients before, during and after their operations. We will offer you expert advice on the types of anaesthetic available. The choice of anaesthetic depends on your general health and the type of procedure that you are having. If you have any existing medical conditions, then your anaesthetist will take these into account and discuss your options with you. Your anaesthetist will come and see you at the pre-admission clinic on the day of your operation. They will discuss a number of things with you, including the types of anaesthetic appropriate for the procedure you're having, and any risks or side effects associated with that anaesthetic. They will plan your anaesthetic and pain control with you, taking into account any preferences you have for a particular type of anaesthetic. This is a good time to ask questions and to tell the anaesthetist about any worries that you have. Your anaesthetist will carefully monitor you throughout your operation and make sure you wake up comfortably afterwards. They will also help with any pain relief you might need after the operation. We offer 2 anaesthetic options for patients having hip or knee surgery. With a spinal anaesthetic, a local anaesthetic is injected near the nerves in your lower back to numb your body from the waist down. You'll be offered deep sedation, which lets you sleep and relax, but some people prefer to remain conscious throughout. In this case, you can bring some music with you to listen to during the procedure. The advantage of a spinal anaesthetic are that you may feel less drowsy and confused. You may feel less nauseous or sick. You'll be able to breathe on your own without support. You may not need strong painkillers, and you may be able to eat and drink normally after your operation. There are side effects associated with a spinal anaesthetic. You may not be able to move your legs properly for a while. You may lose the feeling that you need to pass urine for a while. You may feel itchy. You may have a headache, which we can treat. You may have damage to nerves, although this is very uncommon, usually less than 1 in 50,000 cases. A general anaesthetic gives a state of controlled unconsciousness, during which you feel nothing. We will give you anaesthetic drugs, either injection or a gas to breathe, strong pain relief, morphine or something similar, and oxygen to breathe. We sometimes give you a drug to relax your muscles. You'll need a breathing tube in your throat to make sure that oxygen and anaesthetic gases can move easily into your lungs. If you have been given drugs that relax your muscles, you will not be able to breathe for yourself, and a breathing machine, a ventilator, will be used. A nerve block can be combined with a general anaesthetic to keep your joint numb and pain-free for several hours. It will involve an injection of local anaesthetic near to the nerves which go to your joint. You may not be able to move your leg fully during this time. Spinal anaesthesia is highly recommended for rapid recovery and is found to be patient-friendly. However, your preferences are important to us, so we will always take these into account when planning your care. Whatever type of anaesthesia is used, your anaesthetist will stay with you and watch your condition closely throughout your surgery. After your operation, you'll be transferred to the recovery area, where you'll be monitored until you're ready to go back to your ward.
When you're safe to leave recovery, the recovery staff will call the ward, and one of the ward nurses will come to recovery. They'll introduce themselves to you, and they'll take a handover from the recovery staff, who will tell the ward all the information they need to keep you safe once you're back on the ward.
In our state-of-the-art King's Elective Orthopaedic Centre, a dedicated team of surgeons, anaesthetists, nurses and therapists will ensure you get the very best of care.
Okay, so that just summarises what we've already seen on the other video. Let's take that a little further now with this next video. Let me just move this out of the way.
A general anaesthetic will put you into a controlled state of unconsciousness. This is to ensure that you are comfortable and pain-free throughout your operation.
When it is time for your surgery, a nurse will escort you from the ward to the anaesthetic room, which is next to the operating theatre. This is where you will receive your anaesthetic before going through for your operation. Here, an anaesthetic assistant will introduce themselves and check your details again.
See, dated today by the patient and by the surgeon. So, sir, when was the last time you had food and drink?
The assistant will help you to lie on your back on the theatre bed and will attach some monitors to measure your heart rate, blood pressure and oxygen levels in your blood. A small drip will be placed at the back of your hand through which the general anaesthetic drugs are given. This allows the drugs to flow directly into your bloodstream. Just before the anaesthetist starts to give you the anaesthetic drugs, you will be given an oxygen to breathe in a mask as you drift off to sleep.
Those nice thoughts in your head, and you'll just be floating on. And we'll do our best to help fix your eye, and we'll see you in about an hour's time.
When you have gone to sleep, the anaesthetist will pass a breathing tube into your throat. This tube is connected to a special anaesthetic machine to make sure you continue to breathe easily while anaesthetised. Once you're anaesthetised, you will be moved into the operating theatre on your bed for your operation to start. While you're asleep, you may be given fluids and other drugs such as painkillers, anti-sickness medicines or antibiotics through the drip in your hand. This is so that you wake up feeling as comfortable as possible. The anaesthetist will stay with you throughout your operation to monitor you all the time to make sure you remain asleep and stable until your surgery has finished. After your surgery, you will be taken to the recovery room where you'll have your heart rate, blood pressure and oxygen levels measured by a nurse. You may be wearing an oxygen mask if you've had your general anaesthetic. The recovery nurse will check that you are comfortable, not feeling too sick or drowsy before you go back to the ward.
Hello, you're ready to go back, okay? Are you comfortable? No pain? Okay, I'm just going to give a hand over.
On the ward, you will have your eye checked and your final set of heart rate, blood pressure and oxygen levels checked. You will then be given something to eat and drink. You'll also be given instructions on how to care for your eye at home after surgery.
So that's obviously for eye surgery as opposed to hip replacement, but it just gives you that little bit of extra detail as to what is going on with the anaesthetic. So let's have a look then at the considerations we would have as therapists. So firstly, before the operation, we saw this lady walking in for her tests, her medical tests, and you saw that she was limping, and this is just a still from that video, and you can see the angle of her pelvis, even with her shirt sort of moved. So when you consider that she will have been walking like that for, perhaps months at a time, and with the sort of current pandemic, the waiting list is increased and increased. So she will be deconditioned in that she's lost her sort of fitness and her muscle tone, and she will be compensating for the pain that she's got in that leg. Because of her age and her deconditioning, she will often have comorbidities. So she may be diabetic, she may have high blood pressure, she might have knee pain, she might have had spinal surgery, etc., etc. So we've got a combination of pain, deconditioning and changes that those will occur or will cause in terms of balance, coordination and particularly confidence and function. So when we're looking at treatment nowadays, we talk about a biopsychosocial approach. So the biology would be the tissues, in this case the hip joint, but the psychology would be the fear of movement, the lack of confidence, and the sociology would be how they can walk across a pavement. Do they need a stick? Is their bedroom upstairs or downstairs when they get home, etc. So the biopsychosocial approach looks at the whole patient rather than just focusing on the hip joint itself. So let's now move on and look at the operation. So we'll play the video first and then we can take in a little bit more detail.
Hip replacement surgery has been termed the most successful operation of the 20th century. It has changed many millions of patients' lives.
Very mobile ball in the socket.
And it's a British success story. The original surgeons, engineers and manufacturing companies were based in the United Kingdom, and it's something we can be rightly proud of. What patients want is a pain-free hip that functions well. Hip replacement surgery is very successful in relieving pain. I think patients notice the day after surgery that the pain they had has gone. We replace the bits that are damaged. That does the same job as the hip. So we're very happy for people to cycle, to swim, play tennis, the sort of normal day-to-day activities they enjoyed in the past. So hip replacement surgery.
Just going to move some of this text off the video so that we can see a bit more clearly.
Hip replacement surgery, that the pain they had has gone. We replace the bits that are damaged. That does the same job as the hip. So we're very happy for people to cycle, to swim, play tennis, the sort of normal day-to-day activities they enjoyed in the past. So hip replacement surgery for over 90% of patients is for arthritis. There are other conditions that patients may have and present with, but by far the majority are arthritis. Over time, the hip becomes damaged, the bones develop extra bone on them that make them stiff, the soft tissues become thickened and contracted, and that causes stiffness. So the patient may have difficulty reaching their foot to put socks on, tie shoelaces. They have difficulty throwing their leg over a stile when out walking or getting onto a bicycle. Everything in their day-to-day activity becomes difficult.
So we're scrubbing up now to reduce the bacteria on our skin. Infections are great concern for any joint replacement. We're in a special theatre where there's a high flow ventilation system which reduces the bacteria in theatre to negligible levels.
The hip is a ball and socket joint. The socket is on the pelvis, the ball is on the thigh bone that allows movement in all directions. An amazing range of movement. As the hip becomes arthritic and the joint is damaged, the range of movement reduces. The bit that is damaged in arthritis is the ball and socket joint. The hip replacement replaces the ball of the joint, and the thigh bone itself has actually got a canal in the middle. And that allows us to place the stem into the thigh bone.
Table up, please.
The hip joint in most patients is fairly deep, and it's got important blood vessels and nerves at the front. It's got an important nerve at the back. I use a posterior approach to the hip, so the patient is lying on their side, and it's called posterior because the access to the hip is behind the thigh bone.
I use the diathermy to help stop the bleeding as we go, just stopping all the little blood vessels underneath the skin that ooze afterwards if we don't do something about them now. So it's time well spent.
Because the hip is a deep joint, there aren't any real approaches that allow you to just separate the muscles. Every operation, all the approaches, release some of the muscles. The posterior approach that I prefer releases none of the muscles that take part in walking.
Now the retractors. To position the retractors carefully, not catch the nerve at the back of the hip. This is the top of the hip joint, and now we're just releasing the superficial layers. And to know where the nerve is, you just feel where the nerve is. It's down there. Homan, please. So I'm just identifying the piriformis tendon, which is the top end of my incision. We're going to protect the sciatic nerve which lies behind. So the nerve runs along here I'm going to release this by moving the legs. I'm approaching the hip joint from the back, so I'm releasing some muscle off the back of the femur here, off the bone, so it comes off as like a sheet of muscle. You can leave the muscle on, but as you move the hip around during the operation, it usually comes off, so you might as well take it off carefully at the beginning of the procedure. So one thing I use, which is not particularly common, is a pin to measure leg length. So this pin goes above the hip, and I'm putting that horizontally across the hip. So there's two things. One, it acts as a retractor, and two, it acts as a leg length measuring device. I'm going to measure 7 centimetres.
Very important in all patients to optimise leg length. Then the hip will feel more natural to the patient, it'll move more freely, and there's less chance of it coming out of joint.
She was short by several millimetres before we started. So I'm now going to dislocate the hip. This is the femoral head. Now I'm just going to check that my pre-operative digital templating was accurate.
One of the essential parts of the planning prior to surgery is templating. All patients come in different shapes and sizes, as do their hips. So we have a software program that allows us to choose implant sizes. It helps us identify those patients that might be more complex, and it gives us a better opportunity to end up with a hip with all the muscles are at the right length and the hip feels more natural to the patient. I have a choice on this system of every single company's implants. We have in this hospital 6 different hip systems, and so I try and find the right system for this individual patient. I've decided she's an active lady, she's got good quality bone, so the computer automatically gives me a best guess. Now that is too small for that patient, so I can increase the size of the implant. It's that size stem. I'm trying to put it in the place that nature had the normal hip. So in this patient, that reproduces the hip anatomy. But before I do any cuts, once the hip is exposed, I can place a trial against the patient's natural bone to see whether my planning on the computer is actually going to be right for that patient. So the middle of the hip is there. This is the implant that I thought fitted, and that looks right too. I can see the less trochanter. I can reference that. So on the x-ray that was 15 millimetres, 1.5. Then I divide the neck on the thigh bone, which allows the ball to come away. So the ball and the upper part of the neck is discarded.
So this saw is going from the bottom to the top. So that is the femoral head. And the femoral head should be covered with cartilage. So you can see in this lady, that's solid, like ivory. And that's where it's worn away. That's the arthritis. I now need to approach the socket, the acetabulum.
So the next part of the operation is to release enough soft tissues just to be able to move the thigh bone out of the way so we have direct access to the socket.
So Hannah's holding the femur away so the soft tissues are tight. This retractor helps me release the soft tissues safely. So I'm just going to remove some of the soft tissues. Anterior retractor, please. So the socket from my point of view is looking like this. What I need to do is put a retractor over the front so that I can see. So that goes over the front. This is quite a wide retractor. So Hannah's going to hold that for a minute. I'm just going to release it a bit. What we're going to do. MIS. So that's over the front. I'm now going to release at the bottom, so I know where the normal socket is. So what I'm looking for is the rim, the edge, the bony rim. I want no soft tissue in the way. So I can see all the way around the acetabulum from the front to the back and at the bottom without anything in the way.
And then we prepare the damaged socket with hemispherical reamers that start small and increase in 2mm increments.
So this is a reamer, and it's basically got holes on it and a cutting edge. So basically this goes in to the acetabulum and prepares the surface.
If we make it too small, then the implant will be loose. If we make it too big, then we're going to be damaging natural bone.
So we're going to start off, this is 46. The first one, we have to be careful because it may be soft. This one's quite firm. Yeah. That's the first one. So we want to ream away the damaged cartilage, but not the bone. This one. So that's what we planned. That looks all right. So you've taken away the articular cartilage, which is the bit that wears away, and then just into the bone. So what we call the subchondral bone, just below the cartilage. You don't want to go too far, the bone then gets very soft, and also then the cup is too far in, so it has to be sitting in the right place. So this is the cup. So you can see on the outer surface is roughened.
Just pause the video there. I will give you the link to this if you want to see the whole thing through. But essentially we can see that it's a pretty technical operation, but it is also, you know, quite mechanical in many ways. So you've got saws and you've got drills, etc., etc. So, you know, you're cutting through tissues, you're whacking things, you're burning vessels, you're putting the leg into unusual positions. So when the patient comes out of surgery, obviously they're going to be extremely sore. So let's have a look at how we're going to prepare them for. So before the surgery, we need to have the pre-operative exercise routine. So we're considering the general health of the patient, the increase in their sort of cardiovascular demand and reducing the joint load. So that's what we want to do. So they're already limping, so we want to pick exercises that don't put stress and strain on the hip joint, but get their breathing rate to increase, get their heart rate to increase, to make them as fit as they can be prior to surgery. And then we also need to say, well, is there anything that we can do to try to help the leg itself, so that when we come out of surgery, the rehabilitation is a little bit easier. So that would be more joint specific. So I've put here in the right column things such as quads setting exercises, short range quad exercises, gluteal setting movements, you know, guarded squats, so sort of quarter squat movement. You may be able to do someone holding a wall bar or a, you know, the kitchen work surface at home, single leg balance, hip hinge type movements for sort of hip stability. And then because they're going to be on crutches afterwards, we want to strengthen their arms up a little bit. So armchair push, like a tricep dip from the armchair, hip scissor actions on the hip if they're able to do so, if they're able to get onto their side. So what I'm going to do is I'm going to pause, and I'd like you to come up with a program. So your task then is to come up with a 6-week pre-operative program. So that's a program before they have their operation for a 60-year-old. So this person's had hip pain for 2 years. They've deconditioned, so they can only do a sit to stand movement twice, so they can only get up from the chair twice. They're overweight by 15 kilograms, and they get pain following a 10-minute walk. So we want a program which is going to target their general health, and one which will target the leg and the sort of lower body as best we can. Okay, so let's have a look at this then, and hopefully you came across a few problems in that we're pretty limited with the sorts of things that we can do. So the first consideration would be to say, well, they don't have a gym, they're at home, what sort of activities can they do? And often within physiotherapy we use what's known as sink exercises, that is standing at the sink or standing at the kitchen work surface with your hands supporting. So it's a fairly high support so that they can do gentle movements around the hip. And I've put things such as quad setting, gluteal set. So this would be an isometric contraction, but you need to teach that. They don't know what an isometric contraction is. So factors to consider would be, firstly, how they're going to do it. Once you've got that contraction working, instruct them not to hold their breath. How many repetitions are they going to do? How hard are they going to do it? So I might say to them, well, you just need to do 3 repetitions, and the first one you're going to do quite firmly, and then you're going to relax, take a breath. The second one you're going to do a little bit more firmly, relax, and then the third one you're going to go all out, and you're just going to do 3 repetitions, tightening your bottom up, 3 repetitions, tightening your thigh muscles. Now, that may not seem much, and it's not a great deal, but where they've been deconditioned, it may be all that is realistic, and you're going to do that 2 or 3 times a day. We're then going to work on some form of general health. So if we're in a normal time and they can swim, then that type of thing is great. Or if they go into the gym and they've got a static bike, and again, that would be good. So what we're doing there is non-weight bearing or partial weight bearing. Now, in a pandemic, they can't do that, but what they can do is they could be sitting at home and they can just be moving their legs forwards and back. So lifting their feet up and down, moving their legs forwards and back, doing upper body work with dumbbells, or just do food cans, so a can of beans in each hand, doing a shoulder press type movement, or doing shoulder abduction movements, and then we need something pushing, so some form of pressing action, and I've listed there the armchair push, something to give them a little bit of strength in the arms. And I would aim to do about 15 minutes morning and evening. And what you're trying to do is to get their heart rate to increase, and explain to them that they want to be slightly out of breath, but they want to be comfortably out of breath. So they're not going to be absolutely shattered, but they don't want to hold their breath. And we normally guide them with the talk test, and we say, well, when you're doing your 10 or 15 minutes, you should be able to maintain a conversation. And I will often list these exercises with a little tick box after them, so that they can tick those off. And once I've demonstrated the exercises, I'll normally, if they've got a phone with them, I'll video those so that they've got their own little video of things that they can do. And we're going to gradually build that up over that 6-week period, so they should be fitter at the end of the 6-week pre-op program than they were at the beginning. So we're doing prehabilitation, trying to get them into as peak a physical condition as we can. Okay, so they've had their operation, then you've seen what they've gone through. Now let's have a look at the rehab post-op?
Hip replacement surgery has really changed over the last 30 years. We're getting people up sometimes on the same day as surgery, and it's safe to do that. We are getting people home after a couple of days after the surgery, and it's safe to do that as well.
For your first 24 hours when you get back from surgery, you'll be seen regularly by the nursing staff. The routine on the ward is that from about 6 o'clock in the morning, you might be given your medications by the nurses at the end of their night shift and have your observations taken. Somewhere around 8 to 9 o'clock, the doctors will come round and visit and see you for the day. The physios will come 1 or 2 times each day. There'll also be the nursing assistants on the ward who will pop in and out on a very regular basis every couple of hours to make sure that you're okay. And if you need a nurse at all in between times, you'll have a patient call bell that you can press to get the nurse's attention.
Somebody comes around and checks your blood pressure, checks if you need any codeine or paracetamols. I didn't feel at all hungry. I think I just wanted to stay in bed and recover. But I know I felt fine, and I slept quite well.
For the first couple of days after the operation, you'll receive strong painkillers, either morphine or oxycodone. The strong painkillers can make you feel drowsy after the operation, and they can make you constipated, so you will be prescribed some laxatives to prevent that, and they can make you feel a bit queasy, so we will prescribe some anti-sickness medication as well. For the majority of your medicines, they will be given to you by the nurse. The reason why we do this is that you may be a bit sleepy after surgery and so may not remember to take them. And also there may be some that need to be stopped for a little while. For example, your blood pressure may well go down after surgery, and so the nurses will measure your blood pressure and won't give you your blood pressure tablets if your blood pressure is too low.
It was quite sore. Just, I guess anaesthetic had worn off. The wound was having an effect. And I had to be very careful changing position in bed, which was quite painful if you did it quickly.
We will do everything we can to manage your pain. We're not going to say there's going to be no pain because you've had a big operation and you are going to experience some pain. So when you start feeling some additional pain, if the pain starts increasing, make sure you ask for those extra painkillers earlier rather than later so that we can get on top of the pain as quickly as possible. Please don't feel leaving it to the last minute because you don't want to bother the nurses is what you should do, because it's much harder to control the pain once it's got too far.
After your hip replacement, the physiotherapy team will help to get you up and get you mobile. We'll either see you the day of your surgery or the next day, and we'll be looking at going through some exercises on the bed, then hopefully getting you up, getting you walking around a little bit using a Zimmer frame, and then progressing from there. It's best to try and get up and moving as soon as you can. It's not only better for your hip joint, it will be less stiff, and you'll be able to get it stronger by getting moving quicker, but it also reduces the risk of chest infections and pressure sores and blood clots by getting you moving early. You're more than likely going to be using a Zimmer frame for 1 or 2 days, and then straight onto some crutches. The advantage of crutches is that they allow you to walk in a much more normal walking pattern, so they bring normal movement back quicker.
We try to help you to get mobile as quickly as possible, and obviously to get home as soon as possible. They help you out with the leg that's been operated on. The other leg is quite mobile, obviously, and you follow your injured leg. You followed your operated leg.
So it's common after hip replacement surgery to get swelling. When you are in the bed and you haven't been up with the physiotherapists, then it may well be in your buttock or the top of your thigh. Once you start getting up and walking, it travels down your leg, so thigh gets swollen, ankle gets swollen. Sometimes on the ward we find that patients' slippers don't fit. So when you're at home, it's really important that other joints don't get really stiff at the same time. So it's important to take yourself off to bed, have a lie down on the bed for half an hour in the afternoon. That elevates your legs, the swelling goes down, and then you'll be able to get up and move again.
The top line priority is that you are medically well after this surgery. That has to be done. We need to know that your wound is clean and healing up nicely. The physiotherapists need to know that you're safe and comfortable moving around, probably using elbow crutches, and occupational therapy needs to be sure that able to return to do the jobs that you need to do at home. We're going to come around pretty soon after you've had the surgery, encourage you to get into your day clothes. For many people, the hip will feel a little bit stiff, and it'll be very similar to how you're getting yourself dressed now. We do know that toilets can seem quite low after you've had a hip replacement surgery, and when you're on the ward, the staff will take you into the bathroom and see how you're managing. If you can't manage to get on and off a standard toilet, we are able to loan you a piece of toilet equipment to take home with you. We do ask that you return that after 6 weeks.
The plastic toilet, which obviously meant that you didn't have to bend your leg when you go to the loo, and that was pretty important. The thing for getting your socks on, which I've got one upstairs, also once you managed it, that was fantastic. I had a bit of a problem working how to put the sock on and then pull the sock up onto your foot. But once I managed that, that was okay.
We'll send you home walking with elbow crutches or walking sticks, whichever you're more comfortable using. And we tell patients that you can progress off them whenever you feel confident, but the most important bit is how well you're walking. So I would say that most patients after a hip replacement look to use them around a month, and then if they're walking nicely without the crutches, then that's fine, they can start progressing off them. But if they come off them and start limping, then they need to go back on them for a while and retry. Some patients go down to one crutch, and it's important that they have the crutch in the opposite hand to their surgery.
I certainly used both crutches for a fortnight, and you use your good leg to take the weight of the leg that's been operated on. Get rid of one of them and kept on with the other, usually using the stick further away from the leg, and use that for another couple of weeks or so, and then decide I didn't need them.
The safest way to do the stairs when you go home is to hold on to one rail and have your crutches in the other hand. So hold one crutch as you normally would. What we do is we turn the other one 90 degrees so that the patients can carry up the stairs and then go up.
So just going to pause there, and there are a couple of things here to note. These things are important to the individual. So these are functional movements which most patients will say, well, you know, this is more important than anything else in the first week after surgery. So, you know, the toilet seat raise, the thing to put your socks on. It seems very basic, but it's a personal need, and it's something which patients will often worry about. And if you have a patient where they've had surgery, just liaise a little bit with them, because it may be that for some reason, you know, something has been missed out. And I had a patient recently where they still had problems getting their socks on. They didn't know how to do it, and so you can instruct them on that type of thing. And then the crutches, you know, we're keeping the crutches going for about 2 to 4 weeks after the surgery. And you know, what does the crutch do? It enables you to walk more normally by taking some of the weight off the painful hip. So in a way, the longer you stay on them, the fitter you can become. When the patient's at home, they may not need the crutches, so they can just, you know, use pieces of furniture to get round. And then the patient there made a nice little comment. He said, well, you know, you follow your operated leg around. So what you're trying to do is sort of lead with that leg and take the weight on to the other leg. So you're sort of aware of your operated leg. And then things such as transfers, so that would be standing from sitting, coming up and down from a dining chair or normal chair, from the sofa, going up and down stairs. These are all things which patients worry about, because there's always this fear of, oh well, if I fall, if I trip, will my hip come out of joint, you know, will it dislocate? So taking them through those functional movements is very, very important. So going upstairs is hard. The hardest one is coming downstairs, because obviously you can see where potentially you're going to fall, or you're going to end up if you did fall. So that type of confidence is important, and that is why in the pre-op phase we do exercise the legs to try and do some prehab to get them some leg strength, so that they can now use that leg strength that we invested time in. And the same with the crutches. You know, if you've never used your arms before and all of a sudden you've got to take half of your body weight on crutches, you end up with more pain around the arms and the shoulders. So if we can train those beforehand, then so much the better.
With your good leg first, follow that with your operated leg, and then the crutches that you're using.
I'll send you home with some injections that you have to do every day into your tummy. These are to help prevent blood clots, because you're not walking around at home as much as you would usually prior to your operation. You're at higher risk of blood clots. These two things combined will reduce that risk and make it much safer for you.
Everybody who has hip surgery has a daily injection of doltiparin or fragmin. However, if you're one of these people that are taking oral medication to thin your blood, things like warfarin, clopidogrel, apixaban, you will probably only have a couple of injections and then get back onto your oral medication as soon as possible.
Because of the operation, I'm told that there's a possibility that you might get a blood clot or something. So you get a lump of my stomach it was, you just put it in, press the thing, and do it once a day, and that's it. So if I did it at the same time every day, I'd remember to do it.
So your relative can come and pick you up. You should be ready by about lunchtime. We may ask you to vacate your bed prior to your discharge if we need it for the patients coming through that day, and we have a discharge lounge that's staffed by a staff nurse where they can look after you until your relatives are ready to come and pick you up.
We do know socks and shoes can be a bit of a challenge, particularly socks. There are gadgets available on the open market. Our League of Friends shops sell these items of equipment. You can get them readily out on the marketplace.
To get in and out of the car after surgery, we advise that you get into the passenger side at the front. Whoever's driving you needs to push the seat back as far as it will go and maybe recline the backrest a little bit. You're going to go in bottom first, so you're going to sit yourself down, and if you've got long legs you might want to consider moving yourself back to the middle of the seat, and then bring your legs slowly round into the car.
I very gingerly got into the car, getting help with my hands to get the left leg to follow the leg that was in the car at the time.
Patients go home whenever they're ready, so once you've hit your milestones of being independently mobile with your crutches, your wound is nice and dry and healing, you're happy going up and down the stairs, we know that your home is set up, then recovery will be much more comfortable for you at home. It's been shown that if you stay longer in hospital, then the complication risk increases again, even if you are mobile.
Now I'm just going to pause that there. This is a consideration. So this is a hospital in Oxford. That is a lovely house and you've got loads of space, etc., etc. Somewhat different than a terrace in Stoke-on-Trent where you've got sort of 6 children and you're unemployed. So you need to consider the functionality. So if you've got a steep staircase, it may be that you're not so much teaching a person how to get up and down stairs. You say, well, is there a way for 2 or 3 days you can sleep downstairs, for example? Do you have a neighbour who can come in to assist? The other side of things is somebody may not have anyone. So there's an awful lot of people who are living alone, and they may be embarrassed to say this, but they may have nobody to call on. So there becomes, you as therapists become a little bit of a social worker trying to organise these things and say, well, is there a neighbour? Perhaps let's go and have a chat to this neighbour. And if you ask the neighbour if they would help, then they would probably say yes, whereas the person themselves may be a little bit embarrassed to help. So don't naturally assume that people have all of these things readily available.
We advise patients to do exercises 3 times a day after their hip replacement. They'll They'll find in the beginning it's quite sore to do them, so we advise that they do maybe 5 repetitions, 10 repetitions, and then gradually increase as they become more comfortable. So you should eventually be aiming to do them 3 times a day, 15 or 20 repetitions of each one. If you're somebody who goes home and doesn't do your exercises, then the likelihood is that you won't walk in a normal pattern, you won't get a good recovery, and you're likely to have pain for longer.
You feel stronger each day. You're able to walk more quickly, you're able to do more stairs, take on slightly more. It's a slow process, but it's something that you do just to help yourself.
Try and go for a walk every day outside if the weather's okay, and make sure that you're aware of how far you're walking out, because you need to come back. So if you go for a nice walk, you're out for maybe 10 minutes, you come back, you feel okay, pain is nice and controlled, you're not too sore, then that's really good. That's a sign that you can then increase the amount you walk next time.
After about 2 or 3 weeks, 3 or 4 weeks, suddenly everything comes right. You're suddenly recovered from your wound, from the operation, and you begin to think, what's all the fuss about? It's amazing how quickly you heal and how you quickly recover. You notice the one big thing is that there's suddenly no pain, and that arthritis that was causing the pain is gone. The operation has been a success, and you're glad you've done it.
You'll find that your recovery is best if you are taking your painkillers regularly, doing your exercises regularly, having a walk outside every day, and resting when you need to.
If you have a shower cubicle, we would suggest that that's okay to step in and out of a shower cubicle. It's an easier action for you to do that. With regard to the healing wound, the nurses on the ward will give you a supply of waterproof dressings, so you'll be able to get the wound wet in a splash way. We wouldn't want you to sit in a bath and soak the wound while it's healing.
In regards to housework, once you go home, you should be able to manage your laundry and your washing up with ease. Things like hoovering you might struggle with a bit more because you're going to be mobilising with crutches, and therefore you won't quite have the balance and the hands free to be able to do that.
We recommend 4 weeks to get back to driving. This isn't just about the hip joint itself, it's about your reflexes and really recovering from the experience of coming into hospital, going back home and getting yourself well. It's very usual for people to be really worried about coming into hospital and having a surgery such as a hip replacement. And we want to give you confidence that everything is going to go well during your recovery. It's important that you are realistic about recovery. This is a big surgery. We do a lot of them, and it's a very usual operation now across the world, but that recovery time just takes time, so don't be disappointed when you go home that you feel very tired. Doing the simplest tasks will tire you. That's completely normal. That's what we would expect.
It just makes you feel so much younger. I mean, pain makes you ages you. You just think, I'll never cope again. But having had the hip done, I thought, I've got that pain. I can really sit up and I can get going and start to plan life again.
It was a very straightforward operation. I was well looked after. Everything went according to clockwork as far as I was aware. Everyone was prepared for me. I was looked after while I was there. I nothing but very good experiences. You feel so much better after it. The pain is gone, you're more mobile, you can do things now that you couldn't have done 6 months or so before. You feel a new person.
Okay, so there's a rider to that, of course, and that is that at the moment hip replacements are not being done, and all of the staff have been redeployed. So when a person does have a hip replacement at the moment, they will need to go and see a private physiotherapist, because all of the physiotherapists in the hospital have normally been redeployed. Second thing to say is that not everyone gets that ideal rehabilitation, so people do sort of slip through the net, and they are often discharged after 4 weeks, and they may be limping, or they may have not been given the right sort of instructions. You know, the world unfortunately isn't perfect. So let's have a look then at 1 week after the operation, and I think the most important thing there is to do very little. So people will often think, well, this is a bit like Star Trek. I'll have my hip operated on and I'll be leaping up and I'll be off running. And YouTube is a bit guilty of that. You know, you'll see people walking out of hospitals on the same day. And it does happen, but it depends on the individual. So I'm always saying to patients, look, imagine that if you had a deep cut in your finger, that wouldn't heal within a couple of days. It would take a while. And so that's what happened to your hip. Yes, you've had a new hip joint, but in order to get there, you've had to cut through the skin and about 3 inches of muscle. So all of that has to heal up. So there's no great rush for doing things with the hip joint itself. But what we do need to do is to make sure that your general health is good. So it will depend, the exercise selection will depend on the type of operation to start with. So in one of the first videos they mentioned about a cemented approach and a non-cemented approach. So on the whole, when you see these YouTube videos of somebody leaping out, it's a modern cemented approach with a young patient. So an elderly individual where you've got poor bone condition, a non-cemented approach will take longer. It will also depend on where the incision is. So on the video there, he talked about a posterior approach, and that has the advantage of avoiding cutting through muscles, but the disadvantage that it is deeper and to a degree more complex. An anterolateral approach is the reverse, so you do have to cut through muscle, but you're closer to the joint, so you're not cutting through as deep a layer. The post-operative period, then we saw it was all to do with function. So self-care, how do you get into the bath, have a shower rather than the bath, how do you get into a passenger seat of a car, etc., etc. How are you going to be setting up for cooking, washing, shopping, etc. if you're by yourself. Side effects of the surgery from the drugs and from the surgery itself. So you're going to feel unwell even though your hip has been operated on and the hip joint is fine. Everything else is the problem. You're going to have bruising, you're going to have swelling. Still got weakness, and I've put that note there that the prehab is important because that will cut down on that post-operative weakness. And once we've gone through all of the logical stuff, so after a month, after 6 weeks, discharge, all the muscles are starting to go, and you saw that chap striding through the forest. Confidence and balance are often things which are left out or not good. And I have seen patients where they've come in with hip pain 2 years after a hip operation, and one of the first things I will do is I will take them into our gym at our clinic, and I'll simply say to them, okay, can you just walk across the floor, walk to the other wall? And the first thing they will do is they will aim to go to the wall, to put their hand on the wall, because they don't have that confidence. Or as they're walking, when they go from one part of a rug or some flooring to another, they will be sliding their feet, scuffing their feet, and so they're afraid of falling. So balance and coordination is very, very important later on. Once the tissues have healed, the stitches will dissolve, and there may be, so the deep stitches will dissolve, the superficial stitches should be taken out. It's at this stage they mentioned sort of 4 weeks to get rid of the crutches. So between sort of 2 to 6 weeks, what are we going to do? So what sort of things do they need? So if you're a personal trainer and you've got a client, or you're involved with a sports team and somebody has had a hip replacement, they'll often turn to you because you're familiar to them. You know them, they know you. So you've got a personal training client you've been training for 6 months, and she has a hip replacement, contacts you for advice about what they should do. So the advice would be to say, well, you normally will have had some prescribed exercises by the physio. I say normally because, again, that may be missed out. So I've come across individuals who haven't had those, or they've had loads of different information and they're not sure which ones to do. So you saw the chap there holding the back of the chair. Often we do it holding the kitchen work surface on these sink exercises, and you're doing flexion and extension movements of the hip, single leg standing movements, abduction movements on the leg. So those are fairly straightforward. What is less straightforward and what doesn't occur to the patient is upper body work, and that can be vital because it's going to improve your health. You can do a lot more on your upper body, and then you're going to build up until they're discharged from the hospital. And on the whole, unfortunately, when they're discharged, they're just forgotten about. And you will find you've got a patient who is nervous, who lacks confidence, who's deconditioned and has poor muscle tone. The operation has been successful in that when they do the x-ray at 6 weeks, or everything is healed and everything is in the right place, but you have an unfit individual. So what are we going to do about that? That's the key place in my mind for a sport therapist. So you knew this person beforehand, they went to the hospital at 6 weeks and they were discharged. Nowadays that will normally be a virtual appointment on the computer. So do you have any problems? No problems. The nurse has checked the scar, it's all healed up. You're able to walk, you're able to go up and down stairs. Any questions for me, Mrs. Jones? No, right, okay, off you go. Now the problem there is, how do they bridge from what they're doing now to perhaps returning to their exercise class or their gym or whatever, which would be their previous fitness level. So we need to develop a progressive program over that 6 week period from the 6 month period, from the 6 week discharge to the 6 week period, 6 month period where they're fit enough to go back to the gym. So there have been various different schemes and protocols to guide you through this, and this is a document which may be useful. This is the NICE guidance, the National Institute for Health and Care Excellence, which had significant physio input into it, and it's about joint replacement. So if you do get into this in any detail, then this document can be useful. Just to remind you then of what has happened. So that is the scar that you see, and obviously that takes time to heal, and so some of the discomfort will be from the skin itself. But you've got the 3 parts to the hip. Then you've got the femoral stem, which goes into the femur, into the femoral shaft, because you've cut the ball off, and that goes into the medullary cavity within the bone. Then you've got that metal head, and then you've got the acetabular component, where the surgeon reamed out the cartilage and the remaining cartilage and the bone, and that was either as with this particular x-ray on the right, screwed in, or more normally it will be cemented in, or it'll just have holes in it for the bone to sort of regrow, and that then has a plastic liner to reduce the friction. So that's what you will see on an x-ray, and that's what's happened to the individual. Now once all has healed inside, there should be no restrictions to what they can actually do. So many of the restrictions that were put about hip replacement were for early hip replacements, but now with the more modern hip replacements, there's no real restrictions. So the restrictions used to be called hip precautions, and those were that you shouldn't flex your hip to more than 90 degrees, so you should sit on a higher seat. You shouldn't adduct, so you shouldn't cross your legs, and you shouldn't twist on your hip. Now, broadly speaking, those are either no longer used at all, or so the hip precautions are generally only used up to a maximum of 6 weeks. And that's really to give people confidence, but with many individuals they may not be used at all, and the reason for that is that they do limit recovery and they limit confidence. So if you're saying to people, well, just be careful not to cross your legs, just be careful not to sit on a low seat, then you're sort of instilling in them a fear that they have to protect their hip, and that's not the case. So on the whole, if we do talk about any of those, we would only mention them when they come up. So if we, if somebody says, well, it's a little bit uncomfortable if I cross my legs, you just say to them, well, okay, just don't cross your legs for just a couple of weeks. So give them a specific time scale to stop that happening, and broadly speaking that would be for the first 6 weeks only. From 6 to 8 weeks we really want to wean them off absolutely everything, so no walking aids, no precautions, driving normally, just return to normal activity, but with the knowledge that for a couple of years they've been underactive. So it is now possible for you to get your fitness, and talk to them about seniors, athletes, and all this type of thing. So people will naturally assume that they're sort of past it when they're in their 50s and 60s, and we need to encourage them and say, well, there are people in their 90s, still running, still doing exercise. So from 3 to 6 weeks, we want a progressive return to normal sport and normal activities, depending on what they do. So if they were a runner, well, get them back into running. If they like playing golf, get them back into doing that. If they're, working on a building site, then that would be the aim. And within 6 weeks, we're moving on to normal activities with no limitations. Now, you might be avoiding things such as high impact activities simply because it takes time to rebuild muscle and to rebuild confidence, but you would be limiting it only if it gave them problem. So if they sort of said, well, if I stand for a long time, or if I'm going for a long run, it's just a little bit achy, we would say, well, okay, don't do that, but do something else instead. And just for the knowledge, really, that improvement will continue for up to 2 years. So don't allow people to give up. They need to continue that improvement. So here we've got a case history then of a 70-year-old female, comorbidities, in other words, things which are wrong as well as the hip. She's got an osteoarthritic knee, and her left is worse than her right, which is only mild. She's mildly hypertensive, so she's got slightly high blood pressure. She's 10 kilos overweight. She's had a left hip total arthroscopy, so total replacement, non-cemented, so it's going to take a little bit of time. 6-week discharge, she had no issues, and now she's 4 months after her operation. She still has difficulty descending stairs. She's got some hip and back pain with some longer activities, so prolonged walking. If she walks the dog, she gets a little bit of discomfort. She's lost her confidence on uneven ground and in crowded shops, and that's very common. She wants to start in the gym. And so she's been referred to you as a sport therapist. What are we going to do? What are we going to do for her? So I want you to take a few minutes and design an exercise program which is going to be a bridge between her being discharged from the hospital, doing very little, being underconfident, to returning to what she wants to do, which is her competitive badminton for a 70-year-old. So you're going to have a look at that then. So this is a self-monitored task. So what I want you to do is have a look at that exercise program, discuss that amongst yourselves, and then sort of have that there as an example for you to use should you come across this patient. So the sorts of things to be thinking about would be to say, well, she has had a hip replacement, she's also got some mildly arthritic knees, so we need to do some non-weight bearing activities and gradually to progress that. We need progressive cardiovascular exercise, and we need to do some functional movement. So at some stage that functional movement is going to include stepping over objects. You might put some weights on the ground in the gym and get her to step over those, stepping on and off a step bench, for example, focusing on stepping down, so sort of eccentric control, lower limb alignment, avoiding knee valgus, for example. Talk to her about the need for back strength and a specific back rehabilitation program. Set up a few things like a little functional circuit in the gym, so a few weights, a few balls, a few rolled up mats, bits of clothing on the floor, so she's got to walk across the floor avoiding those, zigzagging round, moving round. Start off slow, build up gradually, but build up to an intensity, and think to yourself, have out into the back of your mind, this person essentially has the same body as a 70-year-old competitive athlete. So somebody who's still playing touch rugby, somebody who's still doing fell running, somebody who's a yoga teacher, somebody who's still doing competitive weightlifting. They can get to that standard. They won't appreciate that, but you do. So you've got to build that program and build them into a higher level of fitness than they have probably had for the last 10 years, perhaps 20 years. So you've got to sell that to them, and you've got to plan that program, and I'll leave that to you. So that would be our approach. A couple of other things to look at then. So this is a knee replacement, which differs slightly than the hip in that it can be a partial replacement or a total replacement. So partial replacement would normally be just one condyle, whereas your full replacement is the whole knee. There will be a limit to flexion. Some individuals will get to 90 degrees and not a lot further. Now, there's no real reason for that. It's just that limitation isn't that important. Once you get 90 degrees of flexion at the knee and full strength, then you are fully functional for what we call ADL, so the adaptations of or activities of daily living. But you want to try and get the maximum flexion that they can. So when we're looking at our knee replacement, some considerations then. So 2 to 6 weeks, scar healing and elasticity of that scar, because that's right over the part of the knee which is going to be stretched in flexion. Progressing knee fitness, looking for symmetry, so right to left leg balance, coordination, strength. Gradual return to normal activities. After that 6-week appointment, they want to lose their sticks, and what will often happen is they'll go from 2 crutches to 1 crutch which causes them to limp, and that's very difficult to undo that. 3 to 6 months then, high impact activities and running are limited, but they're not definitely out, but you would use alternatives and replacements rather than simply saying don't do it. Focus on gait pattern, on confidence, balance, and the falls prevention, so they will naturally have a fear of falling, not because of the replacement but because of the arthritic knee prior to the replacement. 1 year you're expecting full function, but full function from your perspective. So think of this 60, 70-year-old athlete, that is what this person is capable of, and the most common mistake I would say is not taking the individual to a high enough level of fitness. This is a microdiscectomy where somebody has had a prolapsed intervertebral disc which compressed the nerve, and what's happened is that prolapsing part, so the nucleus pulposus which has come out through the outer annulus, has been removed. From your perspective you will simply see that they have a scar, and they have a tendency to wasting within the lower back, so the erector spinae will be wasted, a tendency to tightness in the lower back, and to asymmetry, so typically they'll lean to one side, and we need to build that back up again in terms of their back fitness. So again, up to 6 weeks, it's the normal sort of work that we've done. Post 6 weeks, then we need to be increasing their back fitness, and we need to build their confidence, particularly to bending, lifting and twisting. So they will not want to bend, and they will be taught all sorts of things about not bending, but we need to get them doing a deadlift type movement. Now that may be, you know, done with a can of water or a rucksack. It doesn't matter what it is, it doesn't need to be within the gym. But up to 6 weeks it's a gradual return to work, avoiding lifting and prolonged bending. After 6 weeks, that's the very thing that we need to do. So, you know, that takes a bit of a sales pitch, saying to them, well, you know, you're not going to do this activity now, but later on it'll be the very activity that we will want. So I will often use an example of a cut on the finger, that when it heals and it forms a scab, you don't want to bend it, because if you do, you'll crack the scab and it'll slough off and it'll start to rebuild. But once the scab comes off and you're left with a scar, you've got a stiff finger, and that's the time you want to bend it. And that's exactly the same with the healing tissues. So the disc is no longer a problem because it's not there, but it's the healing tissues that you're concerned with. Next consideration would be a shoulder replacement. So the shoulder is a ball and socket, but it's obviously a smaller socket and a larger ball, so it's a little bit more complex. And, you know, the movement tends to be a little bit more limited, and the time scale tends to be a little bit more limited, but you can get full function, and I would say the emphasis on strength is probably even greater than it is for the hip, because for the hip you naturally walk, and so you'll get a certain amount of strength even if you don't do any rehab, but in the shoulder you may not. So up to 6 weeks we're avoiding movements at the arm. So we don't want extension movements with full weight bearing. So that's what FWB is. We want to avoid abduction and external rotation. So, you know, putting a coat on, this type of thing needs to be done with caution, and no traction through the arm, so no sort of vigorous pulling. After 6 weeks, we're gradually going to build up, and we will be able to do those things. So it's a progressive increase in range of motion, and with a particular emphasis on strength. Consider symmetry, scapulohumeral rhythm, and traction and approximation. So hand, you know, your body weight through the hand and hanging you can do gradually as you increase it. But you know, that takes time to increase that, and you want to build up that confidence of what happens if you fall, and if you fall and you put your arm out, they need to have that ability. So finally then, what we're considering really is the healing timescale. How quickly do these structures heal, and at what stage are they when you do the exercises? So we know that you've got that injury phase, the inflammation phase, regenerating and remodeling. And the key thing is, in these early phases, do very little. Just allow the body to do its job. In the late phases, remember that they can continue for, you know, in many cases 2 to 3 years afterwards. So when people sort of think, well, you know, I've done my exercises for 6 months, just sort of say to them, well, you know, how long would it take for an athlete to continue to improve? And the answer is that, well, you know, it's not limited. And it's the same with rehabilitation. You can continue to improve. You don't necessarily need to do rehabilitation, but you might encourage them to go to a yoga class or a Pilates class or a dance class, or go to the gym, or, you know, to do something where they're incorporating their rehab. And this is the same thing in terms of our healing timescale, but just to say that the tissues lag. So naturally there's this lag phase where there is no strength and it takes time to rebuild. But what you're aiming for is to rebuild them to a higher degree than they were prior to their operation. So the approach that we're taking then is clinical reasoning, isn't it? So rather than simply saying there's a set number of exercises you do, you're considering the clinical needs. So you say, well, what does that individual patient need, depending on their operation, depending on the person they are and the lifestyle that they lead, depending on their fitness prior to the operation, their expectations. So clinical reasoning then is the thinking process that you as a therapist will go through when determining that exercise program. Now, it will very much depend on your background, so it might be different if you're a physio than if you're a sport therapist, and it may be different depending on your specialization. So, you know, once you qualify, you might be dealing with a lot of seniors, a lot of elderly people, or you might be dealing with a professional football club. But essentially, you're going to use your skills to try to match the requirements of the patient, and those requirements will change. And this is something that you will probably be familiar with, the clinical reasoning cycle. So we're considering the patient, we're saying, well, what are we trying to achieve? What goals are we trying to give them? Have they achieved that? And if they haven't, do we need to reflect on that, change things, and then continue? So we're not just going to say, do this exercise forever. You know, we're going to get feedback from the patient and we're going to chop and change things accordingly. So that's a sort of a rapid run through and an overview of, you know, the pre and post-surgical involvement for sport therapy. And the model that I've used is for the hip, but, you know, I think that will be quite useful anyway, because, as I say, it is something which is very common. A couple of sources of sort of information there. The main one, I suppose, would be my YouTube channel, which is Norris Health on YouTube. We've got over 120 different videos there of different techniques, so manual therapy techniques, needling techniques for acupuncture for the next session that we're dealing with. You've got exercises, rehab exercises, you've got lectures, all sorts of different things. So you've got some sort of follow-up there, and you've got sort of contact details on social media. And what we'll do is we'll have a little bit of a question and answer session once you have had a go at doing those 2 tasks, then your exercise program at discharge and your exercise program for pre-operative care. List any exercises that you have, and I will do my damnedest to answer those. All right, we'll catch up next time.